My name is Sheryl Kingsberg. I am a clinical psychologist. I am a professor in the departments of reproductive biology and psychiatry at Case Western Reserve University School of Medicine. I'm also the chief of the Division of Behavioral Medicine in the Department of OBGYN at University Hospital's Case Medical Center. I specialize in behavioral medicine, but I also treat female sexual problems. I've been in the area of clinical research and teaching and conducting psychotherapy for probably 25 years now. Most healthcare professionals are almost deer in the headlights when it comes to taking a sexual history. It is their belief, misguided, that it will take forever to take a sexual history and to be able to evaluate a woman who comes in with a sexual concern. But the reality is it probably takes way less than 5 minutes, and one of the key things to make sure that this takes a short amount of time is to actually ask open-ended questions. In contrast, if you ask yes-no questions, that puts the patient off. They feel sort of under that rapid-fire, yes, no, just the facts, ma'am, kind of questioning, when in fact, if you ask them an open-ended question, they usually can give you a lot of information within less than 60 seconds. In order to make sure that you really address sexual concerns with your patients, it's important to actually validate and legitimize the idea that, number one, that they are sexual or are entitled to sexual health. And number two, that many women already have sexual concerns, and so you would expect that they might have some questions or concerns. So, for example, you might say, many of my patients, when they come to see me, have sexual questions or concerns. What concerns do you have? And that gives them permission. It validates the idea that they are sexual beings, and it validates the idea that they may have sexual concerns, and you're more than happy to address them with her. And a few pointed questions can usually tease out which problem they're experiencing and whether or not you want to address trying to treat it or whether you want to make that a referral. Patients really respect and appreciate it when you ask about sexual concerns. Even if they don't have any, or even if they're not ready to talk about it, they feel more cared about, they feel like you are comfortable with the topic, that you care about them and their sexual lives, and they think of you actually as a better healthcare provider because you're providing a comprehensive assessment and treatment of their overall lives and quality of life. First of all, ask them if they have any sexual concerns. Actually, it's better to say, what sexual concerns do you have? At that point, you're already guided in the direction that you need to go. If they say, I don't have any today, you can also fill in with, at any point in the future, if you have some, feel free to ask me. If they do have a sexual concern, it's going to be either a problem with sexual desire, a problem with arousal, a problem with orgasm, or a problem with pain. So you've got those 4 guided areas. Once you have, whether it's a pain problem, a desire problem, an arousal problem, or an orgasm problem, you can fill in the information with some pointed questions. You want to know, how long has the problem been present? For some people, it's going to be lifelong. For others, it's going to be acquired. If it's acquired, when did it start? And have the patient help you. Do they have any idea what caused the problem? What were the situations that sort of set them up for this problem? And most of all, with regard to making a diagnosis, the patient actually has to experience distress. It is essential, if you are taking a sexual history, if you are assessing sexual concerns in your patients, that you look comfortable with the topic. Patients are already a little hesitant to talk about sexual concerns. They're often embarrassed. They're often worried that it's not appropriate to talk to you, the healthcare provider. So you need to put them at ease and make sure they recognize that this really is the place to talk about this. One way to do that is to make eye contact. You need to be able to look at your patient, not look away, not look down. It's essential that you not trip over your words or stutter a little bit because you're uncomfortable with the terminology. Practice at home. You know, most of us in women's health care are used to using terms like vagina, orgasm, clitoris, but really when it comes to talking about sexual activity, some of us are a little uncomfortable using terms like cunnilingus or oral sex or coming, things that patients might recognize. That's so important for patients to really feel like you're comfortable with it. And most of all, you really need to sit down. It is really not a good thing if you ask your patients about their sexual concerns while you're standing at the door with your hand on the handle and then say, "You don't have any sexual concerns, do you?" When you're asking your patients about sexual concerns, please try to make it in a private setting. Make sure that she's actually clothed. However, I say that with one caveat. If you're doing a pelvic exam and you want to ask her about pain, for example, or other problems that she might be having while you're examining her, you need to do it in a very sort of polite way, but it's okay under those circumstances to sort of ask some pointed questions. One tip that I would really emphasize, please sit down with your patient. Patients perceive that you care more, that you've spent more time, and that you are really focused on them simply by sitting. Make good eye contact. Please use open-ended questions. To say, "You don't have any sexual concerns, do you?" really gives a message, as opposed to opening the door by saying, "Most of my patients have some sexual concerns or questions. What concerns do you have?" That, to me, is the best way that you can get that door open and then follow up with some pointed questions to figure out whether A, they have a sexual problem, and B, what it is. Once you have, whether it's a pain problem, a desire problem, an arousal problem, or an orgasm problem, you can fill in the information with some pointed questions. You want to know, how long has the problem been present? For some people, it's going to be lifelong. For others, it's going to be acquired. If it's acquired, when did it start? And have the patient help you. Do they have any idea what caused the problem? What were the situations that sort of set them up for this problem? And most of all, with regard to making a diagnosis, the patient actually has to experience distress. If she has, for example, a decrease in desire but isn't bothered by it, you wouldn't treat it. But if a patient comes in and says, "I've had a loss of desire and I'm distressed by it or I'm bothered by it," then you can think about a treatment. For example, if you're thinking a patient might have hypoactive sexual desire disorder, or HSDD, there's a simple screener that can ease your way into that diagnosis. We call it the Decreased Sexual Desire Screener, and it's 5 simple questions to you. It's simply 5 questions that if the patient says yes to the first 4, which really gets at whether they've got a loss of desire and they're distressed by it, and the 5th question is a list of situational factors that might contribute to her loss of desire that would help guide whether she has the diagnosis or whether there are other factors that probably caused her sexual desire problems. So that's a very quick and easy screener that really will make a diagnosis within less than 2 minutes. The key criteria for a diagnosis of a sexual disorder, as opposed to just some symptoms, is distress. Now, many women don't really relate to the term distress. If you say, "Are you distressed?" they may not really know what that means. They'll use terms like, "I'm bothered by it," or "I'm upset by it," or "I want to feel better." So while distress is the key criteria, you don't necessarily need to be literal in using that term, but that's key. When you're considering a diagnosis of a female sexual disorder, for example, hypoactive sexual desire disorder or female sexual interest and arousal disorder, besides the criteria of having distress, you really need to look at other factors that might actually be the cause of the sexual dysfunction, and that would sort of rule that out as a disorder. For example, if a patient has depression, that might be the cause of her having low desire. And therefore, depression really would be the diagnosis and not hypoactive sexual desire disorder. However, it really is a timing issue, because if a patient has depression that is because she has low desire, then really hypoactive sexual desire disorder would be the disorder with the secondary outcome of it causing depression. So it's really not difficult to make that distinction, but it really is about a temporal distinction. One other thing that often makes clinicians a little uncomfortable is the fact that there's a lot of overlap in the sexual disorders for women. For example, women who have a desire disorder may also have arousal problems, or they might have pain problems. And the key is which is the primary disorder, and that's often which came first, sort of chicken or egg. So if a woman has low desire, it makes sense that without desire she may not be able to get aroused much. And if she can't get aroused, then she might have trouble having an orgasm, and she may not get lubricated, so she may experience pain. So it's still hypoactive sexual desire disorder that's the primary disorder, but it makes sense that there's going to be overlap in the other female sexual symptoms. If you have a thought that your patient has a sexual problem, it is certainly within the time constraints of an office visit to take a quick assessment, either using a screener or asking a few pointed questions to see if she meets the criteria for a sexual disorder. For example, you can use the decreased sexual desire screener to assess whether she may have hypoactive sexual desire disorder. That would take 2 minutes or less. If you do think she has a disorder, you can either start treatment or refer her out for treatment at that visit, or if you really are feeling short of time, it's very easy to tell her how important her sexual health is to you and hopefully to her, and that you really need enough time to further assess and come up with a good treatment plan, and she'll probably be okay with coming back for a follow-up visit, and that's the time to try to schedule the follow-up. While primary care and OBGYN healthcare professionals really are trained to be the first line to treat female sexual problems, sometimes it's helpful to use a multidisciplinary approach. Remember, sexual problems tend to have a biopsychosocial context. So even if you're addressing the biologic issues related to sexual problems, sometimes it's helpful to also engage them in psychotherapy, because the combination sometimes works the best. Anytime you feel like you're out of time or out of your area of expertise, just find one or two sexual health experts in your area and make that referral and have a collaborative approach. Patients really appreciate it if they don't feel like they're being sort of sent off someplace, but that this is a collaboration and that they feel cared for. And the sexual health expert can also work with you to make sure that the patient feels taken care of and you get feedback from them.